Thank you, Mr. Chairman. Mr. Martin, in your testimony, you discussed the significant administrative burdens faced by physicians and the impact this can have on their ability to serve patients. And I've heard from physicians in South Dakota and across the country about the burden of prior authorization and the hurdles it can create for patients to receive timely medical care. As you may know, for several years I've led legislation along with Senator Brown called the Seniors Timely Access to Care Act that seeks to streamline the prior authorization process and address the burden prior authorization can have on physicians and Medicare Advantage in particular. Could you talk more about the impact that prior authorization has on a physician's administrative workload and how this impacts their ability to maintain their practice, and maybe more particularly, what impact does it have on smaller practices in rural areas?
Yeah, Senator Thune, thank you so much for that, and thank you for your leadership on this issue. I'll give you a statistic. In the Medicare Advantage program, over 80% of prior authorizations are ultimately approved upon appeal. So, we have created an administrative complexity that is delaying care or access to care for patients. It's creating an incredible frustration and expense for physicians, and ultimately for what? The products or the recommendation is ultimately approved. I think this is an assault on clinical autonomy for purposes that aren't yet identified, and the impact on that is physicians become frustrated. The cost of maintaining staff to assist in this type of engagements from a business perspective is more impactful the smaller the practice. Many rural physicians simply can't afford to engage in this activity. They don't have the staff or the technology that allows them to do this, and it has consequences, and those consequences is they ultimately pull back the amount of Medicare patients that they see as part of their panel, or they close or sell and move into other clinical opportunities.
In your testimony, you discuss as well the different pressures faced by healthcare providers in rural areas. As you know, in states like South Dakota, the large rural areas, healthcare providers face many challenges, including finding and retaining workforce, lower patient volumes, and often older and sicker populations. There was a GA report out in 2021 that found fewer physician practices in rural areas were participating in alternative payment models or value-based care arrangements. Value-based care can improve, as we know, patient outcomes, while also giving providers more flexibility to provide the right care at the right time. So could you talk about the barriers providers in rural areas face to participate in value-based arrangements, and how might we be able to incentivize more participation for these providers in value-based care arrangements?
Yeah, thank you for that as well. So I think there are three important things impacting family physicians in rural areas. One you've identified, which is a lack of access to what I would call an appropriate payment model. They're still very much on a fee-for-service chassis. We really need to move them to a capitated or global payment model that allows them to be multimodal and more patient-centric versus billing-centric. The second thing is we need to connect them to resources, higher acuity resources, in a more real way. There's a lot of innovation through telemedicine and Project Echoes and others, but rural physicians often find themselves isolated from the specialty care that their urban or suburban colleagues have, and that isolation puts a lot of downward pressure on them to provide comprehensive services, but to provide comprehensive services without the support that is readily available to them through technology and other aspects. And then I think the third thing to really drive improvements in rural access, particularly physician access, is removing some of the biases that exist in academic settings where medical students in the earliest days of their career are not getting exposure to the joys of rural practice. And they are often told how hard it is and how unfulfilling it is. And I think you could attest to this, Senator Thune. Many of the physicians that are practicing in rural South Dakota are frustrated, but they are very satisfied with the engagement they have with their patients and communities, and we need to tell that story in a different way.
Absolutely. And if I could just, my time's expiring, but switch to Ms. Pearson quickly. Could you describe your experience with real-time benefit tools and what barriers exist to consumers and providers fully adopting them? That's an issue that I've been involved with for some time, and be curious to know what your thoughts and perspectives are on that.
Thank you for the question, Senator. we've talked today about how consumers represent a very important but limited part of the process for using data and pricing to drive behavior. Certainly, tools like real-time benefit information can help consumers who are able, willing, and eager to shop for care to do so in an informed way. What we need to recognize is that there's a significant information asymmetry between an individual patient who's not a clinician. And as we have moved towards high-deductible health plans and other tools, we have seen that often patients forego preventive care that will keep them well. And I know that's an issue that you have been very focused on, and I thank you for that. And so we need to set them up with the tools that really help them get the care they need at the right cost, but recognizing that they're not doctors.
Yeah, thank you.